students. How are you all? I hope you're all doing great and your preparation is going on great. So I know that the Williams has been updated and there's a lot of panic happening ki, oh my god, now what we should do, what are all the changes, how will I come to know the changes. So not to worry, we are going to update you all the changes. And let me tell you first and foremost, there are not like too much changes. They're very minute changes which definitely you'll come to know before your exam. So whatever you're preparing, continue with that. Don't be in a panicky mode. Just be calm and composed, right? And I'm this partogram. So we all know that initially we had partogram. First was the Friedman's curve, followed by Friedman's curve. Then we had partogram. Then we had modified WHO partogram. Now they have introduced WHO Labor Care Guide. There are certain changes in the WHO Labor Care Guide where, like the alert line and action line, which was introduced by Philop and Castle, that is no more present. And the definition of active phase has been changed by the WHO. The reference time limit of second stage, that it should be 1 centimeter per hour, that's of first stage active phase, that which should be 1 centimeter per hour, that's also changed. So there are changes, I'm telling you there are changes, but I will let you know all the changes and we will compile it. We will be perfect with the changes also, so that we will rock in our exam, right? So don't worry, I'm always there with you to help you all. So now the most commonly used partogram is still modified WHO partogram. If you go back to your hospitals also, still we are using modified WHO partogram. We are not using the WHO Labor Care Guide. But as this has been introduced, it's always better to know what is new. So in the MCQ, if they ask you what is there in the WHO Labor Care Guide, then answer according to WHO Labor Care Guide. Otherwise, stick to your modified WHO partogram itself. Okay? Right. So I liked the WHO Labor Care Guide, to be frank. I liked how they have included, they try to be more compassionate towards the patient. And I felt this is like little soothing to the doctor as well as the patient, where, they're trying to tell you that you have to interact to the patient. You have to be very, patient should feel comfortable during the process of labor. And even labor, if progressing slow, if fetus is fair enough and it's going on good, then you take a planned informed incision, right? So that way this is very nice. Let us go through the WHO Labor Care Guide. Yes. So what are the main aims of the WHO Labor Care Guide? So it is same as our previous partogram ka aims and goals. So the guide to guide the monitoring and documentation of the well-being of the women and babies and the progress of labor. So it is to know the progress of labor. So to guide the skilled health personnel to offer the supportive care throughout the labor. To ensure a positive childbirth experience for the woman. Assess the skilled health personnel to properly identify and address the emerging labor complications by providing reference thresholds for labor observation that are intended to trigger the reflection and specific actions if an abnormal observation is identified. So this is going to help us to identify as well as to address whatever the alerts or the triggers, or when it is going beyond the reference threshold. So we identify it and we address it. Next, this is mainly aiming to prevent unnecessary interventions during the labor. And very important, to support the audit and quality improvement of labor management. So basically, after we finish everything, labor is over, when you have a proper documentation, you can think on it. Where did we go wrong, or how did we manage, and how did this help us? So always having the audit and quality improvement is very important, right? So the principal aims are we are monitoring and we are having documentation of the progress of the labor. We are giving supportive care of throughout the labor for positive childbirth. All the triggers are identified and addressed. Our main aim is to prevent unnecessary interventions in labor. It helps us to support the audit and quality improvement. Okay? Now, there are four principal things which they're going to do in the labor care guide. Yes, now this is a difference. When should the labor care guide be initiated? So, when does the partogram get initiated? So, partogram was getting initiated when it is 4 centimeters dial. Modified WHO partogram is from 4 centimeters of dilatation. But labor care guide gets initiated at 5 centimeters of dilatation. This is a change, right? So modified WHO partogram gets initiated from 4 centimeters of dilatation, whereas labor care guide gets initiated from 5 centimeters of dilatation. Okay, next. So the summary of the key points on starting the use of labor care guide is, so you should use the labor care guide in all women in labor. So there is nothing like only for high risk women or low risk women. So you use it for all women in labor, except that high risk women may require additional monitoring and care. Okay. When should the labor care guide be initiated? You should initiate it from the 5 centimeter dilatation or more. And this is designed to use at all levels of healthcare facilities. It's for PHCs, tertiary care centers, everywhere. You're going to use it everywhere. So it is designed for all levels of healthcare facilities. Okay. So this is how the labor care guide looks like. So let's have a closer look. So there is a, we had alert line, action line, all that is removed. Can you see now? So there are 7 sections. There are 7 sections in the labor care guide. So section 1 is same like the previous name and all that. Section 2 is regarding the supportive care. So we didn't have this section 2 previously. So now we are having this section 2 also. I'll just, yeah. So I hope now it is visible to you clearly. So section 2 may we have the supportive care. And please see before the entire 7 sections, you have the alert column. So alert column are the red flag signs. Whenever these are seen, you have to get alerted that something is going wrong with the labor. So we have only alert column in this. In this new WHO labor care guide, we have one alert column. So on y-axis, you have all the sections where we have supportive care, where we have about baby, where we have about the woman, labor progress, medication, right? And what is your assessment? So section 7 is shared decision making. So, you will see what are all the alerts, and depending on what is the alerts, you will share with the woman. So, you're going to assess what is the problem and you're going to plan according to that. So, you're going to do a shared decision making. That's a very positive sign. No? You're going to inform her and then take a shared decision making. Next, if you observe next thing, so on the y-axis, these are the columns where we have supportive care, which is new. Regarding the baby, we had previously also, but there are certain columns which are more in the baby also now. Regarding the woman, labor progress. So section 5 is labor progress. Section 6 is medication. Section 7 is shared decision making. And you're going to take the active first stage. And what is another thing which is new is you're also having second stage, guys. So can you see that there is also second stage? We didn't have second stage in the previous WHO partogram. So this also includes the second stage. Next, so you have time and hours in the x-axis. So each box is 1 hour, and again you have a demarcation in that which is of 30 minutes. So like 1, 2, 3, 4, 5, 6, 7, 8. And as soon as she becomes 10 centimeters, you have to immediately jump to the second stage. So again, you're going to write the time here. So time may you have to write, 3:30, 4 o'clock, 4:30, 5. So like that, every half an hour, the times will be there, time slots above, and this indicates how many hours has been passed. The below column indicates how many hours have passed. Okay. Now, this is just a brief. Now, I'm going to discuss every column in detail. But there are four basic steps in the WHO Labor Care Guide, that is assessment, plan. So, these are the four basic things which we are going to do here. Assess. Assess the well-being of the woman and her baby and the progress of labor. So these are the three things which we are checking in the WHO Labor Care Guide. We are assessing the well-being of the woman, we are assessing the well-being of the baby, and we are seeing the progress of the labor. So after you assess, you're recording it. You're documenting the labor observations. Whatever observations you're having, you're documenting it. So you assess, you record, and then you check the reference threshold. So you have the alert line, all the alert thresholds. So you have to compare the labor observations with the reference values in the alert column, right? So you have to assess, you have to record, and you have to check the reference threshold. So compare the labor observations with the reference values in the alert column, and then you have to plan accordingly what you want to do. So decide whether and what interventions are required along with the woman, and then document it accordingly. So these are the four steps which we are doing in the WHO Labor Care Guide, right? So first you assess, then you record it, then you check the reference thresholds which are given in the alert column, and then you plan and you make a shared decision here. Wonderful, right? I really like the order and so organized it is. Right, now let us see each section and how do we write or interpret in each section. So starting with the section 1. So these are all the how we are supposed to interpret or write. So I'll be telling you how to write. So section 1 is regarding the woman, like what is name of the woman, parity of the woman. So section 1 is all about the woman. So name of the woman. So you write the full name of the woman, XYZ, followed by you're going to write the parity. Like she is gravida 2, para 1, living 1. So whatever the labor parity, you have to write the whatever is her parity or the obstetric score, you're going to write under the parity. Now labor onset. So you have to write whether it is a spontaneous labor or whether it is an induced labor. Because if it is an induced labor, we all know that induced labor में you have more complications compared to spontaneous. So labor onset you have to write spontaneous or induced, right? Active labor diagnosis and date. So when did she start becoming 5 centimeters? So that date and time you should mention in the active labor diagnosis date. Okay. So for example, let us take that our patient has gone into the active labor to 23rd June. So you're going to write it as 23rd June 2022 and whatever time 3 p.m. or something like that. Okay. Next, ruptured membranes. So when did the membranes get ruptured? Again, that also you're going to write the date and time. So again, whatever date and whatever time her membranes got ruptured, you have to write it. If you don't know when did her when did her membranes get ruptured, you're going to write it as U, that is unknown. Next, whatever the risk factors she has, you have to mention the risk factors, like if she's asthmatic or if she's previous LSCS or whatever, hypertensive, preeclampsia, diabetes, GDM. So this first section 1 I think is pretty similar to what we had previously also, but I think labor onset is something which has been introduced, so we have to mention the name, parity, labor onset, whether it is spontaneous or induced, active labor diagnosis, when did she become 5 centimeters, on which date she has become 5 centimeters, when did her membranes get ruptured, and what are her risk factors. So this is the section 1. Now let us go to the section 2. Section 2 is regarding the supportive care. So if you see the first section here, the example is given. So Mary Jane Williams is her name. Her parity is 2. So she's gravida 2. Labor onset was spontaneous. Active labor, when did it start? That whenever she becomes 5 centimeters, that is 6, 7. And they know what is the time of a ruptured membrane. So they wrote 5. Risk of factors are history of stillbirth and anemia. Okay. Next, coming to the time. So time may, so you have to write like she has come to you at 6 p.m. 5 centimeters. So you write the time as 6 p.m. Next column 7 p.m. Next column 8 p.m. Like that you can write. So next column is supportive care. So section 2 is supportive care. So what all you have in the supportive care are, so this is the section 2. So in section 2 supportive care we have companion. So whether there is somebody standing with her or somebody along with her, that is what companion means. If the companion is there, you're going to write it as Y. If the companion is not there, you're going to write it as N. If woman declines, she tells, no, I don't want anybody, I'm peaceful being alone. Then if woman declines, you're going to write D. Every hour you're going to check for it and you're going to write. See here, this is the alert column. Can you see the alert column? Whatever interpretations are there in the alert column, if you have those interpretations, then it is an alert sign and you circle it. Then it is an alert sign and you circle it. Okay. So N is an alert. N is an alert. If no companion is there, it is an alert. So for example, when she came, there was no companion. Afterwards, there was a companion. So no and yes. So when there is a no, you have to tell her, you can go out and call somebody to stay with her. Right. Next is pain relief. If you have given the pain relief, write yes. If you have not given the pain relief, no. If she declines, if she tells I'm okay, I don't want any pain relief, D. Yes and D are not alert signs, but N is an alert sign. So you have to offer and you have to give her the pain relief. If you have not given, give her. Next, oral fluid, whether she's taking oral fluid or not. So in the active stage, you cannot ask her to, hog something or eat something heavy and all. But they should be hydrated to prevent the dehydration. They should be hydrated. So you can give them oral fluids to be taken by themselves instead of IV line and all. So you ask her to drink some juice or drink some water. So they have to be hydrated. So oral fluids are very important. So you ask them to take the oral fluids. So if she's taken the oral fluids, yes, it's a good sign. But if she has not taken oral fluid, it is an alert. And that alert, what are you going to do? Offer her, ask her to take the fluids. She tells D, declines, that's not an alert. Posture. Posture mein, the interpretation is SP and MO. SP is supine, MO is mobile. So again, we prefer the woman to keep walking around during the labor in the active first stage also. Second stage, she cannot walk, but active first stage also, it's always better for the woman to walk around. So you will ask her to walk around. So if she is mobile, it is superb, no problem at all. But if she is supine and lying down, then it is an alert. You ask her to move around. Okay. So understood the first column, very simple. So first column is the supportive care where we have the companion. Companion mein you're going to write Y, N or D. N is an alert. So whatever is there in the alert columns are the alerts where you have to circle and you have to act according to it. So pain relief also N is an alert. Oral fluid not taking is also an alert. In posture, if she is supine, it is an alert. So for example, this woman, if we interpret here, she came at 6 o'clock, she didn't have a companion and she didn't have pain relief. She was not given pain relief. Right. But she was taking oral fluids and she is mobile. 7 p.m. She got a companion. She has taken the pain relief. She is taking oral fluids, but she is supine, which is an alert again. Okay. So this is the section 2. Now coming to section 3. Section 3 is about the fetus or the baby. So the components which are present in the baby are baseline fetal heart rate. So baseline fetal heart rate should be less than 110 or more than 160. So baseline fetal heart rate should be less than 110 or sorry. So it should be between 110 to 160. The baseline fetal heart rate should be between 110 to 160. Whatever column here it is there, this is all alert. Let me write it in red so that you have an emphasis. So anything which is matching the alert column should be circled. And we have to get alerted and we have to decide what we have to do accordingly, and we have to write in the plan. So baby's heartbeat should be in a range between 110 to 160. If it is less than 110 or more than 160, we have to get alerted. Okay. So here we are going to check the fetal heart rate every 30 minutes. Can you see every 30 minutes it's written? Right. But ideally, in the first stage of labor, if she's a low risk woman, you can measure the fetal heart rate every 30 minutes. But if she's high risk woman, you have to actually check her fetal heart rate every 15 minutes. And if she's in second stage, low risk woman, you check the fetal heart rate every 15 minutes. And high risk woman, you check the fetal heart rate every 5 minutes. So if you observe here we are checking the fetal heart rate every 30 minutes, like considering it to be a low risk woman. Now see in the second stage, this is a second stage column. So second stage column, in every 1 hour you're having 4 columns. So here you're checking the fetal heart rate and writing every 15 minutes. Cool? Understood this one also? So baseline fetal heart rate, you're going to check every 30 minutes in the active first stage, and in second stage you're going to check every 15 minutes and write it accordingly. Next, fetal heart rate decelerations. So we all know that there can be a diesel. So there are 3 types of diesels, guys. There are 3 types of diesels. So interpretation, N means no deceleration. V means variable deceleration. And next we also have one more category, that is L. L suggests it's an alert, and L means late deceleration. So L is late deceleration, N is no deceleration, V is variable deceleration, and we also have one more deceleration, that is early deceleration. Early deceleration stands for E. Okay, so let me explain you what does a deceleration means. So whenever there is a decrease in the fetal heart rate from the baseline on a CTG. So we all know the CTG. In antenatal fetal monitoring, I taught you the CTG, right? So whenever there is a decrease in the fetal heart rate from the baseline by 15 beats per minute, lasting for more than 15 seconds, you call it as a deceleration. If you don't have, it's a no. N you're going to write. So what is early deceleration? So early deceleration is where the decrease in the fetal heart rate, nadir means peak decrease in the fetal heart rate, and recovery of the fetal heart rate coincides with the onset. So in early deceleration, the onset of deceleration and onset of the contraction, nadir of the deceleration and peak of the contraction, recovery of the deceleration and recovery of the contraction. When everything is matching, then we call it as early deceleration. Okay, so early deceleration is uniform, repetitive. So early deceleration is uniform, repetitive, and the decrease in fetal heart rate with onset, nadir, and recovery coincides with onset, peak, and recovery of a contraction. So early deceleration is uniform and repetitive. There is decrease in the fetal heart rate, onset and nadir, and recovery coincides with the onset, peak, and recovery of a contraction. Okay. So early deceleration is seen in second stage of labor. So it is seen in second stage of labor. Next, late deceleration. So late deceleration is so after the peak and recovery of the contraction, there is onset and recovery of the deceleration. Then we call it as late deceleration. Basically, the decel is after a contraction. So after the peak and recovery of contraction, there is onset and recovery of a deceleration. So after the peak and recovery of a contraction, if there is an onset and recovery of a deceleration, we call it as a late deceleration. So this also should be uniform and repetitive. Late deceleration is mainly seen with fetal distress. So when we have a late deceleration, it is an alert. Next, the third one is variable deceleration. So these all will be observed only during a CTG. Right. So variable decelerations, decrease in fetal heart rate, varying with successive contraction. Decrease in fetal heart rate varying with successive contractions is called as variable deceleration. So variable deceleration is decrease in the fetal heart rate varying with successive contractions. Okay. So variable deceleration is mainly seen in cord compression. Variable deceleration is mainly seen in cord compression. Okay. Right. So that is regarding the types of decelerations. So if we go back to the interpretation column, so you are checking the baseline fetal heart rate followed by you're checking the fetal heart rate decelerations. If anybody wants to know more clearly about the fetal heart rate decelerations, please watch the antenatal fetal monitoring video, guys. It's available in our app, right, where I've discussed this in more detail, right? Okay, next coming to the amniotic fluid. So amniotic fluid, we all know that amniotic fluid will tell us regarding the status of the baby, right? So if amniotic fluid is intact, there is no rupture of the membranes. Now let us, I hope you all understood the alerts of baseline fetal heart rate. Alert is less than 110 and more than 160. Whereas fetal heart rate deceleration alert is whenever we have a late deceleration. Apart from that, if we have no diesel or if we have variable diesel or if we are having early diesel, that is fine. But if you have a late deceleration, it is an alert. Now coming to the third column is amniotic fluid. So amniotic fluid may first and foremost, if membranes are intact, you have to write it as I. I means intact. If membranes are ruptured, then comes the colors of the amniotic fluid. If it is a clear fluid, then you're going to write it as C. If there is meconium, then you're going to write it as M. And again in meconium, depending on the, how thick the meconium is, that again is a finding of the examiner. So sometimes it is very diluted, sometimes you can see the flakes inside it, sometimes it becomes very thick, full green like cow dung jaisa. So if cow dung is like fully diluted in water, it is grade 1. So that is 1 plus. So 1 plus is non-significant, very light green it is. 2 plus means you're seeing some flakes also. If it is thick like green palak sauce, then 3 plus. If you are seeing 3 plus or B means blood stain, that means again abruption, right? So if you see blood stain liquor or if you are seeing thick meconium, it is an alert. So if you are writing plus plus plus, it's an alert. If you are writing B, also it's an alert. So these two are the alerts for the amniotic fluid. See again, here they have also included fetal position, guys. Usually we didn't have fetal position in our previous. So fetal position again can be interpreted while we are doing the pervaginal examination, right? So fetal position may, we all know that. So positions again we have learned in the labor. So this is the occiput. So if occiput is towards the pubic symphysis, it is an occipito anterior. So if it is occipito anterior or if it is occipito, so how will I do? How will I feel this in the PV? So I'll feel the posterior fontanelle. So posterior fontanelle is easily felt, and if it is just below the pubic symphysis or if it is 1/8 away on the right side or left side from the pubic symphysis, it's fair enough, not it's good. But if it is towards the ischial spine, either right side or left side, it is an alert. So LOT or ROT is an alert. LOT or ROT is an alert. Similarly, if it is towards the sacral promontory, LOP, OP or ROP, then also it is a alert. So transverse position and occipito-posterior positions are the alerts in this. Whether it can be left, right or direct, still it is a alert. So if it is occipito anterior, you're going to write it as A. If it is occipito transverse, then you're going to write it as T. If it is occipito posterior, you're going to write it as P. So P and T are alerts. So we have to see that labor might progress slow, but we can just wait and watch. It doesn't require like some immediate intervention. It just means that labor will progress slow. Next, coming to the caput. So caput may, if you are having 3 plus, so caput is again the swelling. So caput is swelling in the fetal head because of the accumulation of the scalp vein circulation, right? We also call it as caput succedaneum. So again, caput they have given it as plus, small caput, double plus and 3 plus. So it's mainly the venous stasis leading to the accumulation. So diffuse swelling of the scalp, right? So if you have 3 plus caput, it is an again alert. If you have 3 plus caput, it's an alert. Moulding, we all know that there are 3 grades of moulding again. So moulding may grade 1 is just an approximation of the parietal bones. So grade 1 is approximation of the parietal bones. So again, moulding also grade 1, you're going to just write sutures opposed is grade 1, 1 plus. If there is a reducible overlapping of the skull bones, you're going to call it as plus 2, grade 2. If it is an irreducible overlapping of the skull bones, then it is plus 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 3 plus. So irreducible overlapping of skull bones is 3 plus is a alert. So what are all you're checking in the baby? You're going to check baseline fetal heart rate and fetal heart rate deceleration. Amniotic, these both you are checking every 30 minutes. So these both are every 30 minutes. Amniotic fluid, fetal position, caput and moulding. In this, what are the alerts? 3 meconium 3 plus or bloodstain liquor is an alert. Position posterior or transverse is an alert. Caput 3 plus or moulding 3 plus is also an alert. So if you have any of these, you have to get alerted, and all these are checked by pervaginal examination. And during the active first stage, you do the pervaginal examination every 4 hours. So you're going to interpret all this only every 4 hours, not too early. So we are going to interpret all this, or you're going to write or document this by assessing and assessing every 4 hours. Okay. So I hope all of you are clear with the babies column. Now coming to the women's column. So in the women again, pulse. So this column I think is pretty simple, guys. So pulse में अगर pulse is less than 60 or if it is more than 120, it is an alert. So pulse less than 60 or more than 120, it is an alert. If it is in between that, it's fine and good. Systolic blood pressure less than 80 or more than 140 or equal to 140 is an alert. Diastolic blood pressure more than or equal to 90 is an alert. Temperature less than 35 or more than 37.5 is an alert. In urine, proteins plus place and acetones plus place is an alert. So again, how frequent are you going to measure all this? You're going to measure all this again every 4 hours. If anything is abnormal, then probably you're required to do frequent examination depending on your local guidelines. So he didn't mention any guidelines. If there is an alert, he just told you can do according to your local guidelines. So as such, when everything is normal and there is no alert, you are going to measure all this every 4 hours. Okay. Next we have labor progress. So labor progress may contractions per 10 minutes and duration of contractions. So again, contractions you are going to measure every 30 minutes, guys. So when you are measuring for the contractions, you have to measure the contractions for total 10 minutes. And in 10 minutes, how many ever contractions you have to write that number. Like if you're having 3 contractions in 10 minutes, you're going to write 3. If you're having 4 contractions, you're going to write for 4. And you have to measure how long the contraction is staying each time. So you have to put your hand on the fundus of the woman and watch for total 10 minutes. In that 10 minutes, how many times the abdomen is becoming strong? That is the duration of contractions. That is the duration of a contraction. So in 10 minutes, if you're having 3 contractions, so when you put your hand and if you observe there are 3 contractions, you will see hardening of the abdomen for 3 times. And every time when there is a contraction, the abdomen will become strong and you have to see for how many seconds that is lasting. So if it is between 20 to 60 seconds, fair enough. But if it is less than 20 seconds or more than 60 seconds, it's an alert. Similarly, contractions, if they are between 2 to 5, it should be more than 2 to 5. It's good. But if it is less than or equal to 2 or more than 5, it is abnormal. Less than or equal to 2 is hypotonic contractions, more than 5 is tachysystole. So that is why they are alerts. And so contractions you're going to assess every 30 minutes. Okay. And in second stage, you're going to measure for the contractions every 15 minutes. In second stage, you're going to measure for the contractions every 15 minutes. So first stage it is every 30 minutes. Second stage you're going to measure every 15 minutes. Now a very nice, we used to have in WHO Partogram alert line, action line, and you people understanding is such a, it used to be so difficult. But here there is no alert line, no action line. It is just plotting X. So as soon as she has become 5 centimeters, you plot a X. After 4 hours, you have to again examine it. And depending on how many centimeters she has become, you have to plot it. Like let us tell that after 4 hours, she has become 8 centimeters. So I'm going to plot it here again. Next, if you feel she has become 10, when they bear down, we understand it's 10. So then you might require to do PV before 4 hours it's also. So you have to take a call sometimes. Ideally in active first stage, every 4 hours you have to do PV. But if you're feeling patient has become full, you can do priorly also. Like now I feel she has become full after 2 hours itself. So I'm plotting it here. Now what is alert? See, the definition of alert is very different in this WHO labor progress care guide. So if she is in 5 centimeters for more than or equal to 6 hours, then it is an alert. So ideally, according to old WHO Partogram, the rate of dilatation in primary or multi, they consider it as 1 centimeter per hour. So matlab, if she is 5, she should become 10 centimeters in next 5 hours. But what is he telling here? If she remains in 5 centimeters for more than or equal to 6 hours, then you call it as an alert. Means he's telling in this new WHO labor care guide, even if the progress of labor is less than 1 centimeter per hour, still it is fine. Very new point. right? These are only the changes which we have. So labor may, whatever notes you have, stick to that. Addition to that, these are the things which have changed. So I am not mixing and making it biryani and masala. I am keeping it separate. So if they ask you as per Williams, those are the answers. If they ask you specifically according to the recent updates of WHO, then go with this. So now, according to WHO, even if the labor progresses less than 1 centimeter per hour, it is fine. Only when are you going to call it as an alert? When if she is 5 centimeters and if the labor is progressing in 5 centimeters for more than 6 hours, if labor is in 5 centimeters for more than 6 hours, then it is an alert. She has become 6 centimeters and she is remaining in 6 centimeters for more than or equal to 5 hours, it is an alert. She's 7 centimeters and if the labor is she's remained in 7 centimeters for more than or equal to 3 hours, it's an alert. If she's 8 centimeters and if the labor is taking more than or equal to, and if she is remaining in 8 centimeters for more than or equal to 2.5 hours, alert. If she's 9 centimeters and if she's remained in 9 centimeters for more than or equal to 2 hours, it is an alert. For example, let us take one case. I have done a PV of a woman at 4 p.m. She is 5 centimeters. At 9 p.m., so this is 4 p.m. At 8 p.m., 5, 6, 7, 8. At 8 p.m., when I repeated her PV, she is 7 centimeters. Actually, according to our previous guidelines, from 5 to 7, if she has taken 4 hours, she would have crossed the alert line. But here, even if she has 8 p.m., she became 7, it is still fine because she didn't remain in 5 centimeters for more than 6 hours. So it is not an alert. And 9, 10, 11. At 11 p.m., if I did PV and if she's still at 7 p.m., if she's still at 7 centimeter dilatation, so she remained in 7 centimeters for equal to or more than 3 hours. She remained in 7 for more than or equal to 3 hours. So now it is an alert. Now it is an alert and I probably require to do something for that according to my guidelines. Understood, guys? So did you understand? So now that 1 centimeter per hour minimum dilatation is not a criteria. So even if they have less than 1 centimeter per hour dilatation, that is fine. So when are we going to call it as an alert? When she remains in 5 centimeters for more than or equal to 6 hours, it is an alert. When she remains in 6 centimeters dilatation for more than or equal to 5 hours, it is an alert. When she remains in 7 centimeters for more than or equal to 3 hours, it is an alert. When she remains in 8 centimeters for more than or equal to 2.5 hours, it's an alert. If she remains in 9 centimeters for more than or equal to 2 hours, it's an alert. So in active first stage, lot X, alert triggered when lag time for current cervical dilatation is exceeding the no progress. In second stage, we write P to indicate the pushing. We are going to just write P, push. She's pushing. There's no dilatation here, no? So you have to just write P. Okay. And descent, though there is no alert column. Let the descent progress whatever way it has to, however the descent is progressing. But there is no alert column for the descent in this new WHO labor care guide. So we follow the Crichton's 5/5. If the entire head is above the pubic symphysis, per abdomen, if the entire head is above the pubic symphysis, you're going to write it as 5. If head has little entered, so if let us take this as pubic symphysis and this as head, the entire head is above the pubic symphysis, 5/5. If head has gone inside little and I'm able to feel only the once 4 fingers above the pubic symphysis, then it is 4/5. If head has further gone inside and only my 3 fingers are able to palpate the fetal head, it is 3/5. If head has gone further inside and only 2 fingers are able to palpate the fetal head, 2/5. Similarly, 1/5. And if I'm not able to palpate the fetal head and if the entire head has gone below the pubic symphysis, then you're going to write as 0. So descent plotted every 4 hours. Accordingly, how the descent is progressing, you have to write it. Okay, but there's no alert column for the descent. I feel it is more easy compared to Partogram, to be frank. So I hope you all understood WHO Labor Care Guide progress. Let me know if you have any doubts in the comment box. Okay. Next, section 6 is medications. So if you are giving any medication like oxytocin, you have to write how much oxytocin you are giving. And one more important point. So we have discussed regarding the first stage. First stage, what is the alert I have told? Now, what about the alert for the second stage of labor? So, alert for the second stage of labor is, so alert value for second stage of labor is when more than or equal to 3 hours in nulliparous woman, more than or equal to 2 hours in multiparous woman. So, if the woman is full for more than or equal to 3 hours, it is a second stage arrest, right? You might require to take off a cesarean section, and that is an alert for the WHO labor care guide. If more than or equal to 2 hours, if she is full and the baby didn't come out, it is an alert in the WHO labor care guide for multiparous women. Okay. Now you might ask me, why is this change of such slow labor? So what they have observed by doing the study, you might ask me, why are they changing it so much? कि कभी उन्होंने बोला, once they told active phase starts from 3 centimeters, then they have changed it to 4 centimeters. Now they have changed it to 5 centimeters, and now they are telling even if the labor progress is less than 1 centimeter per hour, it is still fine. Why are they doing that? It is all evidence based. They have studied multiple women and they found that even if the labor progresses less than 1 centimeter per hour, they still achieved normal vaginal birth. There was no need for creating a hype and going for cesarean or doing some intervention when the dilatation was less than 1 centimeter per hour, because they ultimately achieved vaginal delivery. So that is why here they are telling, let the labor progress slow, wait till whatever reference limits which they have given. If labor doesn't progress beyond that, then you go for interventions. So indirectly they are doing all this to prevent the unnecessary interventions. So in studies they found that even if the labor progress is less than 1 centimeter per hour, still normal labor was achieved. That is why they have increased the reference time limits. Okay, right? So I hope it is clear. Now again, labor progress में contraction and duration of contractions, you're measuring every 30 minutes in first stage, and second stage you're measuring every 15 minutes. Labor progress, that is cervix and descent, you're measuring every 4 hours. Active stage में you decide how frequent depending on you want to do the PV, because anyway it is seen there. So section 6 is regarding the medications. So if you are giving any oxytocin, you have to write the international units, drops per minute, how much you are giving. If you are giving medicine, write what is the medicine which you are giving. If you are giving IV fluids, write yes. If you are not giving, write no. That's all. So there is no alert in this. There is no alert in this. So it just means how much you are giving. You have to write that. So that is why there is no alert here. And whatever medications you are giving, accordingly write it to the time and the medication which you are giving. So after everything, section 7, you have to assess. You have to write the assessment. What was happening and whether it's going wrong or correct, it is a normal progress or whatever it is. You write the assessment. And then you write what is a plan which you want to do. Right? So this is regarding the WHO labor care guide. Now what will I do is, we will see the example which was provided by the WHO. We'll discuss that same example so that we will be well versed and understand what I have discussed better. Okay. So now we'll see the example provided there so that we understand it better. So in the supportive care, this patient came at 6 o'clock and she was having no companion and no pain relief. She was drinking fluid. She was mobile. So this was the 6 o'clock interpretation, that first 1 hour. And fetal heart rate was 140 followed by 136. There were no deceleration, so N and N. Amniotic fluid was clear, but fetal position was occiput, posterior. Caput was not there, moulding was not there. Pulse was 88, systolic blood pressure 120, diastolic 80. So all these are in the normal range. Temperature 36.5, no protein, no amniotic fluid, no acetones. So that's also no alert, right? She was getting 3 contractions of lasting for 40 seconds, 3 for lasting for 40 seconds. She was at 5 centimeters. Descent, fetal head was at 4/5. No oxytocin was given, no medications were given, no IV fluids. So in the first 1 hour, there were only 2 alerts. She didn't have any companion and there was no pain relief. So pain relief required, but she's having normal progress. So that is what is my assessment after all the record what I've done. So what is the plan I'm giving? Offer companionship and relaxation techniques. Continue the routine monitoring. This is the plan which I have written. Understood. Now next. So section 1 you're going to record every 1 hour. So again every 1 hour you have checked. So alert was supine position. So you can offer her to walk around. Section 2 you check every 4 hours. So let us go with the 4th hour now. So she didn't have again companion. She didn't have pain relief. She was supine. But her baseline fetal heart rate was 151, 133, which is normal. Heart decelerations, they were variable, but that is not alert. Late deceleration is an alert. Amniotic fluid as now meconium is there, but thin meconium, so only plus it is given. Fetal position has now changed to position posterior to transverse. So T they have written, it's still an alert, but yes, we can wait for the progress to happen. There's one caput and there's one moulding, that's fine. Next, coming to the pulse rate and all. So pulse, blood pressure, temperature, all were in normal range. Contractions were also 3 contractions lasting for 50 seconds, again in normal range. Now after 4 hours, she has become 8 centimeters. So she has progress. It is not an alert. Very good way of progress. So I'm going to just. And she has descended from 4 to 3. That's fine. There's no alert for here also. And you have not given any drugs to her. So as she didn't have pain relief and not taking fluid, so pain relief required is my assessment, normal progress. So offer companionship, pain relief, encourage mobilization, continue monitoring. So whatever are the alerts, accordingly you're going to write, and whatever is what you want to write, plan you'll write there. So understood. Now after 3 hours, after 3 hours she became full. So that's why I checked after 3 hours itself. So again she is supine, caput is plus, moulding is 2 plus, and now she became full. So after 3 hours itself she became full. So after she became full, I went into second stage. Second stage mein again same you're going to measure. Baseline fetal heart rate, early decelerations were there, but still it is fine, right? And then she was having adequate contractions and you're asking her to push, so you have written PPP. And then after that, when there is a birth, you have to write when the birth, time and birth, okay? See, normal progress, continue monitoring, and then there was a birth. So this is how we are going to interpret the labor care guide. I hope you all understood. So it is a pretty simple way of interpreting and simple way to write and simple way to understand also for every level healthcare providers, right? So this is regarding the labor care guide, and these are the updates which we have in the labor care guide. So I compile the updates again. So now according to WHO, the labor can begin active first stage of labor is more than 5 centimeters of dilatation. Update number 2, labor progress can go less than 1 centimeter per hour dilatation. That is still fine. Update number 3, second stage of labor is when you have to get alerted in the second stage of labor is when in nulliparous woman labor is gone beyond or equal to 3 hours, and in multiparous woman when it is gone beyond and more than 2 hours. So these are the updates we have according to the labor in WHO by WHO. And I hope you all understood the WHO labor care guide. If you have any doubts, feel free to message in the comment box. Yes, we are going to help you all by sharing this video so that you all get a crystal clear idea ki what are the updates and what is there. There are some more updates. Yes, I am going to post those updates also to all of you. So be happy, study well. All the best, guys. Thank you so much.